Dr. Narayanan, State IAP President, Dr. Basavaraj, Secretary, National IAP, Dr. Ananda Keshavan, Vice President, Central IAP, Riyaz sir, senior members of the profession, dear colleagues and friends. This is the first talk, maiden talk of a series of talks in pediatric subspecialties named as Rainbow. Actually, we planned only 5 talks initially, and he has named it as a rainbow. As a joke, I told him there are 7 colors in rainbow. Then he made it a 7 weeks talk. Every week, 3 talks. My duty is to welcome you all. I welcome Dr. Narayanan, State President IAP, who will preside this meeting. And I also very happy to welcome Dr. Basavaraj, Secretary General of Central IAP, who will inaugurate this program, as well as Dr. Ananda Keshavan, Vice President Central IAP, who will give a keynote address. And I also welcome my respected teacher, Dr. Riyaz sir. He needs no introduction to this audience. An astute clinician, excellent teacher, respected by and loved by all of his students. I welcome you all for this meeting. I also extend warm welcome to the all participants joined in this Zoom meeting. Welcome you all. Over to Dr. Narayanan for presidential address.
Good evening to you all. Am I audible?
Yeah, audible.
Yes, warm good evening to you all. I have great pleasure to be with you today to chair this session. The rainbow with 7 colors. And today it is the violet color. Violet is a color of imagination, future, dreams, and spirituality. So each color has got its own significance. We are starting with violet. And today we have our chief guest, Dr. Basavaraj. And I think today is his birthday. I wish him many happy returns of the day. And it is the first time that he is attending a webinar hosted by any branch in Kerala State IAP. And you know, Basavaraj's team has taken webinars in IAP to a level, an unimaginable level. The number of programs we are having daily, the number of attendance that is having. I fear whether people will be attending regular conferences if webinars are going with this much success in future. So it's my pleasure to have Dr. Basavaraj here. He is very close to each of us, and he has been with us during last year and during the campaign period. Everywhere he was there. He's very close to our hearts of IAP Kerala. And the speaker today is none other than Riyaz sir, who was my teacher in the undergraduate days, respected by all, loved by all, a doyen of pediatric gastroenterology, and the program organized by IAP Calicut branch. We also have the national vice president, Dr. Ananda Keshavan, who is a member of IAP Kerala, but is doing good work at the national level. So we have 2 people from the national scenario and a good number of participants. I take this opportunity to congratulate the Calicut branch for organizing such a wonderful session and wish the webinar all success. Now, shall I invite Dr. Basavaraj for inaugurating the webinar? Thank you.
So thank you very much, Dr. Narayanan sir, chairperson of the today's meeting, and the president of the Calicut branch, Dr. Ashraf sir, secretary who has taken all the efforts to organize this, my good friend, Dr. Niyaz, and today's guest of this session and our none other than our South Zone Vice Chairperson, Dr. Anand Keshavan sir, and our star faculty of the day, Dr. Riyaz sir. He doesn't require any introduction. Sir is a very popular teacher across India, is known for his clinical skills, very popular among the postgraduate. His textbook of pediatric gastroenterology is one of the most read book by the postgraduates across India. Of course, other senior member, Dr. Vijay Kumar, Dr. Ranjit, and Purushottam sir, and many of them I know, but I don't want to name things. All the members of Calicut branch. It is my pleasure to inaugurate it online. This is the new way of life with under this COVID situation. But I am very happy Calicut branch has taken an initiative to conduct this academics at the local level. Already more than 100 people are logged into this program. It shows the commitment of a Calicut branch led by Dr. Ashraf and Niyaz. They are taking no stone unturned to make this program. Is a wonderful. As Narayan sir is already put it, it is in a rainbow thing within a seventh thing within a violet color today. And this week there are 3 scheduled talks. Just I was going to 3 talks. They are very, very relevant to the pediatrician. One is a liver function test for the pediatricians. This is going to be delivered by Dr. Riyaz sir. So tomorrow is another session. It is a palliative care, Dr. Lulu Matthew sir. And one more on immunology by Geeta Govindraj. They are all an excellent faculty. I am sure all the Calicut branch people is going to be benefited with this academic. This is a new norm. They will take it to the greater heights without wasting much your time. I wish you all the things, all the best for this webinar. And also I thank all the Calicut branch people wishing me their happy birthday. Thank you, Narayan sir, once again. I am sure under your leadership, IAP Kerala will achieve this year something good, phenomenal in the IAP Kerala history. Thank you so much, Ashraf sir, Niyaz, and our Vice Chairperson, Anand Keshavan. Thank you so much for giving me an opportunity to come and inaugurate at this lockdown. Over to Dr. Ashraf sir.
Narayanji, continue. Invite for keynote address.
Thank you, Dr. Basuray sir, for inaugurating this session. Now it's over to Anand Yashwan, our own National Vice President. Over to Dr.
Am I audible, Narayana?
Yeah.
Can you hear me?
Yeah, sure. Continue.
Very good evening.
Audible. Anand Yashwan, continue. Audible.
Respected Chairperson, Dr. Narayanan, today's chief guest and birthday boy, Dr. Basavaraj, favorite teacher, Dr. Riyaz sir, President of the IAP Kozhikode, Dr. Ashraf, and the entire team. At the outset, I would like to congratulate the office base of IAP Kerala and IAP Kozhikode for arranging a wonderful CME program, series of programs. And I think there are 2 important aspects of this one. One is all the speakers are from our own speakers, local speakers. So they are very good and very proven. They are talent in different fields. So that is also another important thing. I think that is a very great achievement. So I would like to congratulate the team IAP Kozhikode entire team. I think now it is even after this lockdown, this webinar should continue because here there is no registration fees. We need not to travel. We need not to go behind the drug pharma. It is environment friendly. Baswara sir. So
Yes,
even after the lockdown season, there are so many advantages of the webinar. And you can sit in the Bangalore and you can talk to all India and all over the world. I think even though the lockdown is over, we have to continue at least in another manner. We have to continue the webinar series. The topics already we mentioned are included all very good topics in different specialties, subspecialties. The vibrant branch is Kozhikode. The dynamic great academician, our teacher, Dr. A Riyaz sir. So I don't want to spend much more time. I wish the series of webinar all the success. Again, I would like to thank the IAP Kozhikode team for inviting me for this function. Thank you. Jai Hind, Jai IAP. Over to Narayana.
Thank you, Dr. Andreshwan. Now, without wasting any more time, shall we go to Dr. Riyaz sir for his deliberations?
Yes. Over to Riyaz sir.
Hello? Ashraf, can you hear me?
Yes, sir.
Yes, sir.
Yes, sir.
Audible, sir.
Okay.
Yes, Riyaz, you are audible.
Okay, thank you. Good evening, everybody. Respected Dr. Narayanan, Dr. Baswaraj, Dr. Ananthakesavan, Dr. Balandran. I would like to thank the dynamic organizers of Calicut IAP, Dr. Ashraf and Dr. Nihas, for giving the privilege to talk to you this evening. Ashraf, kore aalkare keran pattilla ennu enne vilichonde irikkunnu keta. Ashraf, is it possible? Because yesterday we had 230 participants.
Sir, ഇന്നലെ ഒരു corporate account ആയിരുന്നു sir. Even though this is a paid account, the entry is restricted to 100.
അതെനിക്ക് അറിയില്ലായിരുന്നു കേട്ടോ. So many people are still.
നമുക്കും അതിനെപ്പറ്റി ഒരു ഐഡിയ ഉണ്ടായിരുന്നില്ല. കാരണം
And we're going for streaming, Facebook streaming. That is what I've seen in other cases where it costs 100.
രഞ്ജിത്തെ നമുക്ക് ഫേസ്ബുക്ക് സ്ട്രീമിങ്ങോ യൂട്യൂബോ പറ്റുമോ? രഞ്ജിത്ത്.
Sir, we are recording the stock. We will upload in our YouTube.
Okay. So we shall be discussing liver function tests. Now I would like to begin with a few warnings to you, because this is a dry topic. Liver function tests are always a dry topic, just like chronic constipation, which involves dry stools. So I'm afraid some of you may feel bored, especially because I had given a talk yesterday and there may be some repetition of yesterday's slides also. So I may be pardoned for that. But my promise is that I will not discuss complicated biochemistry. LFT is full of biochemistry and I will not discuss complicated biochemical reactions. I shall discuss mainly through case scenarios. And I hope this to be an interactive session. I'll be projecting questions, and if possible, you can write the answers in the chat box, so that the last session of a question and the session may be about, and this time can also be given to me. Ashraf, okay. So the liver, as you know, is the second largest organ in the body, and it is rightly called the chemical factory of the body because it's a vital organ. Without the liver, we cannot survive. Look at this slide. So the amazing functions of the liver. See, a synthetic function is responsible for synthesis of albumin, all the coagulation factors, for glucose homeostasis. Remember that without the liver, gluconeogenesis will never occur. Got still several other functions. That means that you simply cannot survive without the liver. And Professor Sheila Sherlock, the doyen of modern hepatology, had once remarked that the multiple functions of the liver are only exceeded by the equally large number of biochemical tests which are designed to test them. But I would like to add a note of caution here, because, as you know, one good clinical history followed by a meticulous clinical examination are actually worth 10 LFTs. So this means that we should not do unnecessary investigations, which include LFTs also. So always take a very good history and conduct a meticulous clinical examination. So what are LFTs then? These are actually serologic tests to evaluate for liver disease. As you know, the term LFT is actually a misnomer because most of these tests reflect only the hepatocellular injury. They do not test the functions of the liver per se. For example, when the transaminases are elevated, what does it mean? It just means that the hepatocyte is inflamed. When the alkaline phosphatase is increased, that means there is some biliary tract injury or there is cholestasis. The only synthetic functions are reflected by the serum levels of bilirubin, albumin, the prothrombin time, and the INR. So this slide shows the synthetic tests, albumin, prothrombin time, and INR. The excretory functions are tested by the bilirubin, cholestasis by alkaline phosphatase and GGT, hepatitis by the AST and the ALT. So if you compare LFT, you can compare LFT to the players of the chessboard. Of the various tests, I would always say that prothrombin time is the most important. Why is it so? Suppose you got a child with hepatitis. To do the prothrombin time, you find that the prothrombin time is prolonged more than 4 or 5 seconds. This is a very significant observation because this child may be having fulminant hepatitis. On the other hand, if the prothrombin time, the INR of a child with hepatitis is normal, you can be rest assured that this is not going to be a problem. This may not be fulminant hepatitis. So the most important, suppose you are asked to do only one investigation in a child with hepatitis, that should be prothrombin time. So what are the indications for LFT? So the first and foremost indication is any child with jaundice will always do an LFT. It has to differentiate between different types of liver disorders. Is it an acute liver disease, is it a chronic liver disease, is it a cholestatic liver disease, is it hepatocellular disease? So it's possible to differentiate these types of liver disorders. Follow the response to treatment. For example, suppose you've got a patient with autoimmune hepatitis, you monitor the transaminases. To know the extent of liver damage, for example, if the prothrombin time is prolonged, that means that almost 60% of the hepatocytes are already damaged. Then whenever you start treatment with hepatotoxic drugs, for example, anti-tuberculous treatment or anti-epileptic treatment, it's very important to monitor SGPT and if possible, serum bilirubin. Nowadays, there is another bizarre request by some of the parents, especially parents who have just arrived from the Gulf countries. They come to the hospital and say they want a full checkup, not only a clinical checkup, but all investigations, including vitamin D, LFT, and RFT. Okay. So in Western countries, especially the United States, remember that SGPT is done in all blood donors to screen for transmissible viruses. In our country, we screen for HPV, HIV, etc. But in the Western countries, especially the United States, they always do the SGPT level of the donor blood. Because if the SGPT of the donor blood is elevated, that is a surrogate marker that this patient may be having some infective process, some infective agent, some virus, some obscure virus in his blood, and his blood is not suitable for transfusion. Now let's come to a case scenario. Well, we had a 3-month-old boy born to consanguineous parents. The mother of this child is was a final MBBS student of Calicut Medical College. One clue is that she had intrahepatic cholestasis during pregnancy. This baby presented with pale stools, high colored urine since birth, had a firm hepatosplenomegaly, and that is an extremely irritable baby. Okay, now let's see so this is the pale stool, and here you can also see the compared to the normal stool. Let's see the LFT. The total serum bilirubin is 10.5, the conjugated fraction is 6.5. The transaminases are only mildly elevated, but look at the SAP, it is a whopping 1,380. So what is the next investigation to be done? Audience, in a baby with cholestatic liver, suspected cholestatic liver disease, the SAP is very high. What is the next investigation to be done? A simple blood test to be done is the GGT. See, normally you expect the GGT to be elevated, but look at the GGT here, it is less than 10, it is very low. So there are a set of conditions in which baby has got cholestasis, but the GGT is normal or even low. What are these conditions? There are some entities known as the progressive familial intrahepatic cholestasis, what is called the PFIC1, PFIC2. Then we have the benign recurrent intrahepatic cholestasis, ARC syndrome, agonist syndrome, and bile acid synthetic disorders. So these are some of the cholestatic liver disorders with a normal or even low GGT. So the genetic studies in this child were suggestive of PFIC1. Let's see another case. Second child of non-consanguineous parents. So this is non-consanguineous parents, and he also had cholestatic jaundice, pale stools and high colored urine right since birth. He had a firm hepatosplenomegaly. He has the dysmorphism. Can you find the facies? Can you describe his facies? Look at his forehead, very broad forehead. Look at his eyes. Apart from the jaundice, he has got deep set eyes, triangular face. Look at the chin, it's a pointed chin. So what's the diagnosis? Anybody? Okay. Anybody with
Alagille syndrome. What's an Alagille?
That's right. That's right, Chef. So let's see the LFT. He has got conjugated bilirubin is more than 12 mg/%. Transaminases, see the transaminases are only mildly elevated. SAP is extremely high. So what's the next investigation in this child? That is also GGT. Look at the GGT. GGT is also equally high. So this is not the conditions. This helps us to exclude the conditions which we have previously discussed. So, or the diagnosis, obviously, as Ashraf has rightly pointed out, this is a case of Alagille syndrome. Now, let's see what has happened to Vishnu at 10 months. 10 months, this is how Vishnu looked. 4 years, you can see that it just has intensified, he looks more sick. And look at it, 5 years. This photograph was taken just a few days before his death. You can see that he has got a bleeding manifestation. What the finding in the teeth? Look at his teeth.
Green teeth.
Yeah, he's got green teeth, which is called chlorodontia. What does it mean? It means that his dentine has been exposed to very high levels of bilirubin right since his birth. So this is another patient, Arjun. He's from a university. This is how Arjun looked at 1 year. In fact, he was referred from a Calicut Medical College to Trivandrum SCT because he had a congenital heart disease in the form of tetralogy of Fallot. So he was referred to SCT Center for correction of his tetralogy of Fallot. And the brilliant pediatric cardiologist of SCT thought that he has got a problem, he's got a liver disease, and hence he was referred to us. So this is how he looked at 1 year. See how he looks at 3 years. Now you can see the typical faces, the broad forehead, the triangular face. You can see the cyanosis because of Fallot, bulbous tip of the nose. See, deep set eyes. And this is how Arjun looked at 5 years, 7 years, and 10 years. In fact, I just spoke to Arjun in the evening just to see how he's, because of the COVID, he's doing fine. So that is the Arjun from 1 year to 10 years. So this is an autosomal dominant disease. It's also known as the arteriohepatic dysplasia. It's got several congenital heart diseases, but the most common one is peripheral pulmonary stenosis. And of course, tetralogy of Fallot is also common in these patients. This is the posterior embryotoxin, which can be picked up by slit lamp examination. The liver biopsy may show intrahepatic bile duct paucity. It got a relatively good prognosis because only 10% of patients develop cirrhosis. Unfortunately, Vishnu fell in that 10% and he died of a decompensated liver disease. What is posterior embryotoxin? Posterior embryotoxin is actually a thickening of the membrane as a sharp. It's one of the hallmarks of Alagille syndrome, and this can be picked up only by slit lamp examination. So this is a very commonly asked question for postgraduates. What are the indications for slit lamp in pediatrics? You mentioned only about KFR, but remember that it's useful in Alagille syndrome also. Another patient, different age groups. You can see the typical faces again. Look at the face. You can see there's some lesions on the face. What are these lesions? See, the last photograph you can see papillar lesions. We have discussed fever and rash study. It's got papillar lesions, yellowish papillar lesions. See, on the hands. These are xanthomas. Here serum bilirubin was more than 1000 mg/cent. So this is another patient with Alagille syndrome. This is Dheeraj from Kannur at 7 years, at 12 years, 14 years. What are the findings? You can see that he has got xanthelasma. His serum, his lipids were also more than 1000 mg/cent, and he's got an anterior staphyloma of the left eye because of uncorrected hypovitaminasis A. This is an arcus juvenalis in the same patient. And let's see another case where a 10-year-old asymptomatic boy born to consanguineous parent. I have highlighted consanguineous parents because this may be an autosomal recessive disease. Okay, anyhow, he was evaluated for recurrent episodes of mild jaundice, high-colored urine. He had mild splenomegaly. His LFT was essentially normal, except or apart from a total serum bilirubin of 5 mg/cent, out of which conjugated fraction was very high, 4.5. All viral markers were absent, and I will show you the liver biopsy. This is the macroscopy of the liver biopsy, and this is the microscopy of the liver biopsy. In a case, what could be the diagnosis? You can see that the macroscopy is the blackish, and the histopathology shows black pigments in the hepatocytes. So this condition is known as black liver jaundice or the Dubin-Johnson syndrome. So familial jaundice is also known as eponymic jaundice. You know why? Because all these conditions have got somebody's name along with them. So that is an eponym. And familial jaundice can be grouped into two categories. We have the unconjugated jaundice as well as the conjugated jaundice. The unconjugated jaundice, the most common one is Gilbert syndrome. Then we have the Krigana, that type 1, which is a fatal disease. And the type 2, which is not a fatal disease, that's called A Riyaz syndrome. What are the conjugated type of familial jaundice? There are essentially two types. Number one is Dubin-Johnson syndrome. The second one is Prof syndrome. Now, what is the genetic defect of Dubin-Johnson syndrome? It's an autosomal recessive disease. You know that one of the functions of the hepatocytes is to secrete bilirubin into the biliary canaliculae. And for that, a protein is required. Okay, this protein is called the multi-drug resistant protein 2. In Dubin-Johnson syndrome, what happens is that the gene for this particular protein is defective. So this protein is not available, and hence naturally bilirubin can be conjugated, but that cannot be secreted into the biliary canaliculae, and instead it leaks out of the liver into the bloodstream, resulting in jaundice. And the liver biopsy will show a black pigment which is similar to melanin. Now, what about the Gilbert syndrome? What is the significance of Gilbert syndrome? Remember that Gilbert syndrome is one of the most common genetic disorders seen in the Caucasians, the incidence being almost 5 to 10%. I've seen quite a few undergraduates as well as postgraduate students with Gilbert syndrome. The serum bilirubin usually doesn't go above 6 mg/cent. So what is it due to? You know that there is an enzyme called UGT1A1, which is responsible for conjugating unconjugated bilirubin to conjugated bilirubin, which now becomes water soluble. Okay, that's shown in the slide here. And there is a mutation of the gene for this. Now, in Gilbert syndrome, jaundice may be aggravated by fasting. Okay, so what's the importance of this statement? Nowadays, we see a lot of our politicians and film stars undergoing fasting. ഒരാഴ്ച ഫാസ്റ്റ് ചെയ്ത് കഴിഞ്ഞാൽ they will be fit as a fiddle. Okay, so why is this happening? Suppose this patient has got, suppose that this particular person has got Gilbert syndrome, and a person like a true sincere leader like Mahatma Gandhi, if he's got a Gilbert syndrome and he's undertaking fast, that will be true fasting. His jaundice will be aggravated. Whereas the politicians, many of the politicians, in the fast, you know that what Jagadish Srikumar does. ഒരു ടോർച്ചിന്റെ ഉള്ളില് പഴം പുഴുകിയ നിറച്ചിട്ട് രാത്രി ഭക്ഷണം കഴിക്കാറുണ്ട്, even though he's supposed to be fasting. So even at the end of 1 week of complete total fast, they'll be fit as fiddle. Now, what is the special problem when a girl with Gilbert syndrome reaches her 20s? Anybody? She's reaching her 20s and she has got Gilbert syndrome. What is the special problem? What's the problem is 20 years? That is the marriageable age. Marriageable age. So what will happen? If she's got Gilbert syndrome, nobody wants a jaundice girl. It's very unfortunate. It's a benign disease. It's not at all a fatal disease, completely benign disease. But nobody wants a jaundice girl. So if you're the doctor, how can we help such poor patients? Is it possible to help them? Yes, it's possible because you can just tackle this by giving phenobarbital. You can start phenobarbital at least 1 week before the marriage. That will activate this particular enzyme which is defective. So jaundice will subside and the marriage will take place comfortably without the eyes of the patient being itching. Any other problem faced by a young man with Gilbert syndrome, especially in Kerala? I've seen at least a few adolescents or adults who are trying to go abroad to Dubai, and they are sent back. They fail in the medical way because they have got jaundice. So I had to write that this is only Gilbert syndrome. Doesn't cause any hazard. It's not a occupational hazard. It does not spread to other people. So anyhow, but sometimes these Arabs may not believe what we write. So what we can do is that before they go for the medical checkup or for their interview, they should be put on a small dose of phenobarbital and the jaundice will subside. Another case, we had a 10-year-old girl with pyrexia of unknown origin. She had cervical lymphadenopathy, puffy eyelids, and minimal hepatosplenomegaly. This is the peripheral smear, a pictorial depiction of the peripheral smear. Look at the bloods. They've got striking leukocytosis with lymphocytosis, mild jaundice. Look at the LFT. The transaminases are minimally elevated. Platelet count is below normal. And we have seen the peripheral smear. All viral markers are absent. Dengue serology is negative. Maybe it's not COVID also. What the most probable diagnosis? Anybody? So PUO, lymphadenopathy, periorbital puffiness is one of the hallmarks of a particular disease. Leukocytosis, lymphocytosis, mild hepatitis. What could be the diagnosis? And with this, the peripheral smear picture.
Many responded in chat box, IMN. Response in chat box.
Who has written that?
IMN.
Because that's absolutely right.
Faisal.
Okay, Fizal. Oh, Fizal is my old student from belonged to 36th batch of Calicut Medical College. He's one of the youngest HODs of a medical college. Where is Faisal? But he's got a wrong name also. His name is unfortunately Fizal and not Faisal. Okay. Anyhow, Faisal, you are absolutely right. This is IMN. But let's see what has happened to this. What are these cells called? These cells have got a peculiar name. No? If you observe the cytoplasm, you can see that the peculiar coning of the cytoplasm. And this can be compared to this particular appearance. These are Russian ballet dances. Look at the skirt of these Russian ballet dances. And these cells are similar to the skirt of the Russian ballet dance. And hence it's known as the ballerina skirt cells. This is because of the peripheral condensation of cytoplasm. These cells are also, what is the other name of these cells in IMN? It's not up.
Downy cell.
Very good. Yeah, that's right, Downy cells. These are also known as the Downy cells. So these are the ballerina skirt cell. Here you can see the original cells also. You can see that the cells are indented by the surrounding red blood cells surrounding RBC. That's the reason why you get a ballerina skirt cells. And IMN is notorious to cause mild hepatitis also. Okay. Another case. Another 8-year-old girl with pyrexia of unknown origin. She also had diarrhea. Her parents and 3 cousins had also similar illness. She had hepatosplenomegaly. See the bloods. Total count is 3,500. Polymer 60%. Platelets are normal. ESR is 55. Look at the LFT. Mild elevation of the transaminases and conjugated bilirubin is also high. That means this patient has got mild hepatitis. Any takers for that? The clue is that they had been on a pilgrimage about 2 weeks back. And parents and 3 cousins are also affected. What could be the diagnosis with this picture? Anybody? Faisal? Babluji, are you there? Kabaldeeps? No.
From
So how will you
BS, typhoid. From
I'll come to that.
typhoid.
Okay.
Yes.
I'll come to that, Ashraf. Now, how will you proceed in such a case? I will give a clue. The clue is this. Now, I'm sure you. Who is this?
Mukherjee. Pranab Mukherjee.
Jyoti Basu.
It's not Pranab Mukherjee.
Jyoti Basu.
It's not Pranab Mukherjee. It's not Pranab Mukherjee. It's not Pranab Mukherjee.
Jyoti Basu.
Jyoti Basu. Now, I wanted to test the GK of some of our postgraduate students a few years back and asked one of the students, a girl, who is Mamata Banerjee? She stared at me for some time and said, sir, I think Mamata Banerjee is the Prime Minister of Himachal Pradesh. I was literally shocked. Mamata Banerjee with the Prime Minister of Himachal Pradesh. Anyhow, this is Jyoti Basu. And how does Jyoti Basu help in the diagnosis of typhoid fever? Because the BASU is an acronym. Blood culture in the first week, agglutination in the second week, stool culture in the third week, and urine culture in the fourth week. Okay, so that is how even Jyoti Basu can help pediatricians to diagnose enteric fever. This is actually enteric hepatitis. I'm sure Ashraf, Geeta, both Geetas, Ajit will always be, all will be remembering the almost epidemic of enteric hepatitis we had a few years back in Calicut Medical College.
Condoti fever.
Pardon?
Condoti fever.
That is typical. That's it. It was at that time called Condoti fever. There are a lot of patients from that particular area. That's right, Ashraf. But the next case, we had a 13-year-old girl. 13 is the striking. Okay, 13 is the unlucky number. From consanguineous parents, I have highlighted some clues for you. Consanguineous parents. She had jaundice, depression, anorexia, and anhedonia. Again, I have highlighted anhedonia of more than 6 months duration. Previously, she had been an excellent student. She had an expressionless face, and handwriting has become small and cramped. That is called micrographia. Her gait was slow. She had tense ascites and hypertonia. Look at the patient. Look at the LFT, the AST. The SGOT is very high compared to the SGPT, almost twice. The SGOT is almost twice the SGPT or the ALT. She has got conjugated hyperbilirubinemia. Look at the albumin, it's very low. What does it mean? Very low albumin means you've got a chronic liver disease. Another clue is that alkaline phosphatase is very low. All the viral markers are negative. Autoimmune markers are also negative. Prothometer is more than 100. Now I will show you the peripheral smear. What are the findings in the peripheral smear? Any takers? Anybody in the chat box?
Many answers. So many answers.
Can see.
Wilson.
What are the answers? Can I see the answers? What are the answers? Peripheral smear shows. You can see a normoblast. Can you see the normoblast in the middle? And there are microspherocytes. So in this patient, there are microspherocytes as well as normoblasts, which means there is some amount of hemolysis taking place. Now, what are the most probable diagnoses? Alkaline phosphatase is very low. The AST is very high compared to the ALT. Microspherocytes in the peripheral smear. Any child with unexplained, that's right. Any child with unexplained hemolytic anemia, always think of the possibility of Wilson disease. This is actually fulminant hepatitis due to Wilson disease, hepatic failure. The peripheral smear finding I already discussed. You can see a normoblast and a microspherocyte. Remember that microspherocytes may be seen in Wilson disease also. What's the treatment for her? Is it dipencylamine, trientine, or ammonium tetrathiamolybdate?
Zinc.
Zinc, are you sure? So come back to the question again now. Autoimmune markers are negative, prothrombin time is more than 100 seconds, and that is a definite indication for liver transplantation. So in this child, no question of medical treatment. This child has got fulminant hepatic failure, and the only treatment option is liver transplantation. This patient requires liver transplantation. Okay, this is the, what is this? Can you see it? That is the KF ring. And what is this? Clue. You want a clue?
Sunflower cataract.
Geeta ji. The clue I used to give, this is, the clue that I used to give, this is not moonflower. So this is sunflower cataract. So who describes sunflower cataract? Anybody? Olof. It's also known as Olof cataract. Sunflower cataract was described by an ophthalmologist known as Olof. It's also known as the Olof cataract. Why the serum alkaline phosphatase is very low in Wilson disease, especially in fulminant Wilson disease? There are so many reasons. A reasonable explanation is that what is the cofactor for alkaline phosphatase? That is zinc. Okay, in Wilson disease, what happens? Copper will displace zinc, so there is no zinc to synthesis for the synthesis of alkaline phosphatase. That is the reason. That is one of the reasons why the alkaline phosphatase is very low in Wilson disease, especially fulminant Wilson disease. And this is one of the markers of Wilson disease, very low level of alkaline phosphatase. So what is anhedonia? Inability to enjoy a pleasurable experience. Suppose you see a very nice joke, you don't enjoy that. Or I will give a clue for anhedonia. And who is this? Is she around?
She's joined the group, I think.
Okay, so this is another one of my best colleagues in the Department of Pediatrics of Calicut Medical College. None other than Dr. P. Geeta is a brilliant pediatric rheumatologist.
I'm here, sir. I'm here.
Okay. So the brilliant pediatric rheumatologist P. Geeta is there. Okay. So what is anhedonia? See, suppose a particular person cannot enjoy even a melodious song by P. Geeta. That means she has got anhedonia. And P. Geeta, as you know, is rightly called the S. Janagi of pediatrics. Okay? So that is anhedonia for you. And anhedonia means the child has got depression. And a child with neurodevelopmental disease will be depressed. So that is the relevance of P. Geeta in today's discussion. Another case. This is actually the 10th child born to consanguineous parents. All the 9 children have died in infancy or early infancy itself of an obscure fulminant liver disease. So all the 9 children died in early infancy or early childhood. So when the 10th child was born, she had married her cousin. So when the 10th child was born, this mother stubbornly refused to breastfeeding. She said that there is a poisonous snake in her breast milk which is killing her babies. That's the exact words which she used. She was absolutely right because we investigated and found out that she was actually suffering from the diagnosis. Obviously, this was a case of galactosemia. So we gave the correct treatment for galactosemia. I'm sure many of my colleagues would have seen this patient. Very unfortunate patient. So she was doing extremely well. Then she was not seen for about 6 months. When she came back, we were shocked to find this child in this situation. You can see he's got bilateral cataract, hepatosplenomegaly, ascites. She developed all sorts of complications and she also died. You know why this happened? They had gone to an homeopathic doctor and he said that milk is the best food for children. Children should always be given milk. So the baby continued to be given cow's milk, and with the result that he developed fulminant hepatitis failure, and this child, the 10th child, also died. You know what the father did? Ashraf, father and the 10th child, then naturally he remarried. He got married again.
Probably divorced.
Divorce, yeah, then I do not know. Anyway, remarried. This is the characters metabolism pathway. I'm not discussing because of the lack of time. A neonate with suspected metabolic liver disease admitted with sepsis. Suppose you have got a neonate with suspected metabolic liver disease admitted with sepsis. And the blood culture shows E. coli. What is the significance of this? Neonate with suspected metabolic liver disease admitted with sepsis. The blood culture shows E. coli. What is the significance? This is a clue for that. What is this? Geeta MG. This is Kijagavadam Attakada. Kijagavada. You know that Kijaga was destined to be killed by whom? Kijaga was destined to be killed by Bhim. So if Kijaga has been killed, that means Bhim and the Pandavas were around. That's how the Kauravas found out that the Pandavas were around. And they built the Arachilum, and that's the story there. So what is the relevance here? The relevance here is that if a neonate with suspected metabolic liver disease has got E. coli sepsis, he had the diagnosis, the metabolic liver disease should be galactosemia. Chattal Kijayanana Konnate Bhimna Varnavadi, neonate with suspected metabolic liver disease with E. coli sepsis, it's going to be galactosemia. Another case. This was this child was actually from Kasaragod. I saw him recently when I was working in Kannur Medical College. He was evaluated by the pediatrician in Kasaragod for a short febrile illness. As a part of the workup, the pediatrician did an LFT also. He found out that the transaminases were elevated. He was not convinced. He thought that something is wrong with the laboratory, and he repeated the test from 3 different laboratories. And all 3 reports were the transaminase was elevated. So he referred the child to Mangalore. So he was evaluated in detail from Mangalore. So what are the clinical features? He had a grade 3 PM, minimum hepatomegaly. The ultrasound scan showed fatty liver. His albumin and ceruloplasmin were low. So from the medical college, a liver biopsy was done, and he was put on penicillin with a provisional diagnosis of Wilson disease. Okay, and he was sent home. So, but even after 1 year, there is no improvement. His transaminase was still high. So the pediatrician became worried, and hence he was referred to us. He did not have any jaundice. He did not have any signs of chronic liver disease. Now, how will you proceed in this? This was indeed a baffling case for us. So how will you proceed? So back to basics once again. This slide I had shown, but this is one of my favorite pet slides. History taking is very important. Second and third, again, I have written history taking, because if you do not take a proper history, you will miss the diagnosis. So then you examine and do the relevant investigations. So pediatrics should always be like Sherlock Holmes, right? So we took the history again and found out that he had mild motor delay. In fact, he was evaluated by a pediatric neurologist in infancy for motor delay. So now, what is the clinical sign being shown in this child with suspected Wilson disease who is on depensilamine? You can see that. What is the finding here? Clinical sign. You can see that the calf muscles are hypertrophy. Okay. What clinical sign will you now demonstrate? Clinical sign is calf muscles are hypertrophy. You the Gower sign. The Gower sign is positive. Okay. What test will you do now? Gower sign is positive. You can do the CPK. The CPK was more than 20,000. So what is the diagnosis here? This was not a case of Wilson disease, actually a case of Duchenne muscular dystrophy. So just by taking a detailed history and a simple clinical evaluation with a very simple test, clinical test like CPK, we could make the diagnosis of Duchenne muscular dystrophy, and he was sent to geneticist. Okay, so that was actually a patient with Duchenne muscular dystrophy. Now, what is this sign demonstrated here? Any postgraduates? What is this sign in Duchenne muscular dystrophy? You're all fond of a sign described only by SIPE on Caucasians, Europeans. This sign in Duchenne muscular dystrophy was described by an Indian neurologist. So clue is that Narendra Modi is the Pradhan Mantri of India. Pradhan Mantri. Pradhan sign or valley sign in Duchenne muscular dystrophy. Okay, so this is a case of Duchenne muscular dystrophy and not Wilson's disease. Another patient was actually referred from a Calicut Medical College, 8-year-old boy with virus A hepatitis. Several members of the family are affected with virus A hepatitis. Okay, but all members recovered. Now the pediatrician became worried when the transaminase of this particular 8-year-old child alone continued to be high even after 1 year. HbA1c was negative, Wilson disease was walk-up was normal, everything was normal, bilirubin was normal. Then we found that his AST is more than ALT. Okay, look at the muscles of this child. So it's very important to strip the child. If you completely strip the child, you can see the thigh muscles are really hypertrophic. Look at his deltoid and his bicep muscle, markedly hypertrophic. And what is the next investigation? Again, CPK is again more than 20,000. So this is also another patient with Duchenne muscular dystrophy and did not have any liver disease. Now, why was the diagnosis missed in both these cases? These children actually had Duchenne or Becker, whatever that's. The history was that both had a motor delay and SCOT was persistently more than SCPT. So when you do the LFT and you find that the SCOT is more than SCPT, that the ST is more than LT, then there are some other conditions. Always think of muscle disorders also. It may not be a liver disease. So what is the cause of hepatomegaly in the first child? That's the reason we had a fatty liver, hepatomegaly, albumin was low. He had also grade 3 protein, almost severe proteinuria malnutrition. So his hepatomegaly was because of malnutrition. His fatty liver was also because of malnutrition and not because of Wilson disease. Why was his albumin low? Again, because of malnutrition. Why is the ceruloplasmin low? You know that ceruloplasmin is also like a protein, plasma protein like albumin. So if the albumin is low, sometimes the ceruloplasmin can also be low. So what is the source of transaminases? AST, that is SGOT, is concentrated in the mitochondria or hepatocytes and also the cytosol. But remember that there are several other sources for SGOT and AST. The cardiac muscles, the skeletal muscles, brain, pancreas, lung, so many other sources. So when these tissues are acutely damaged, SGPT levels will, AST levels will rapidly rise. Okay, but what about SGPT? SGPT or ALT is liver specific. It's present mainly in the cytosol of hepatocytes. maybe to some extent in the other sites also, but it's mainly in the cytosol of hepatocytes. So an elevated SGPT is also always more specific and sensitive for hepatitis. What is the significance of the SGOT-SGPT ratio? This ratio is called the de-risk ratio. So if the SGOT is more than SGPT, always think in terms of Wilson disease, all-cause hepatitis, and myopathy. Various types of myopathies, including muscular dystrophies and other myopathies. Okay. Is all-cause hepatitis seen in children? Now that pediatricians are forced to treat adolescents also, it's quite possible that we may encounter adolescents with all-cause hepatitis, which may be mistaken sometimes for viral hepatitis. So what are the cause of unexpected elevation of transaminases? At the point of the workup, you do LFT and find that the transaminases are elevated. But otherwise, the child is absolutely normal, absolutely no evidence of any liver disease. The one reason is obesity. Obesity is definitely one reason, and a score of other conditions like diabetes, non-alcoholic steatohepatitis, which is a part of obesity, asymptomatic chronic hepatitis B, Wilson's disease, alpha-1 antitrypsin disease. All these conditions can cause unexpected elevated transaminases. But remember that there are other conditions also. And who is this? Who is this? Anybody? It's a very famous man. He's actually a senator. He's a film star.
Arnold Schwarzenegger.
That's right. Absolutely right. This is the very muscular person. SGOT will be elevated. So if you do with the SGOT of Arnold Schwarzenegger, that will be very high. The difficult venipuncture. So the RBCs will be damaged. We already seen that it's present in RBCs. The difficult venipuncture is another reason why the transaminase may be erroneously or falsely elevated. Congenital hyperthyroidism is another cause. And this patient, or the diagnosis here, you can see that she has got, it's not jaundice, it's muddy conjunctiva. She was evaluated for severe weakness, malaise. You can see the pigmented lips. This is actually a case of Addison's disease. The part of a rare condition called Alagille syndrome. We had discussed with MG the other day. Patient with Addison. In Addison disease also, sometimes that can be unexpected elevation of transaminases. Drug abuse. Drug abuse is so common in the Western countries. Similarly, alcoholism. Even teenagers that take the alcohol in a big way in Western countries. So alcohol abuse can also cause an unexpected elevation of transaminases. Celiac disease is another cause. Marathon runners. Nowadays, marathon running is very popular. So you take the blood of these people after marathon running, the transaminases, especially SGOT, may be elevated. Now let's see another case. We had a 4-year-old girl from Panur. This girl I saw when I was working in Kannur a few months back. She was evaluated by one of her pediatrics for jaundice of more than 6. I think she was referred by Dr. Nanthakumar, who is a very good pediatrician in Kannur. Jaundice of 6 months duration. Born to non-consanguineous parents. She had a PEM, minimal hepatomegaly. Bilirubin was normal, 1 milligram, upper limit of normal. Conjugated fraction is absolutely normal, just 0.2 milligram %. The LFT is absolutely normal. Albumin is also normal. All viral markers are negative, right? Now, how will you proceed? This child has got jaundice. The parents are worried. The pediatrician, everyone is worried. How will you proceed? Again, back to basics. Once again, back to basics. So we took the history again. Okay. So what is the history? You know what the history was? We found out that the mother was a WhatsApp addict. Like so many of us who are WhatsApp addicts. I am a WhatsApp addict. So this mother was also a WhatsApp addict. And she got a message that carrots prevent all types of diseases. Okay. So you know what this my young mother did? She gave the child kanji with carrot, milk with carrot, dosha with carrot, and in addition she gave carrot juice also. Carrot maya in the diet. Okay, and the mother started taking herself. So what's the diagnosis here? Diagnosis is carotenemia. This is a simple case of carotenemia. Serum carotene was more than 30 milligram%. So how will you clinically differentiate jaundice from carotenemia? See, carotenemia does not affect the eyes. Eyes will not be stained. Okay, and after a few months, after stopping carrot, you can see that the palm of the child has become completely normal. What are the causes of secondary carotenemia? Sometimes there can be secondary carotenemia also. For example, nephrotic syndrome. In nephrotic syndrome, there may be increased excretion of carotenoids. Cirrhosis, because of the impaired conversion of carotenoids to retinol by the liver. So in decompensated cirrhosis, you can get carotenemia, hypothyroidism, diabetes, all these conditions, anorexia nervosa. These are some of the conditions which may cause secondary carotenemia. What is the cousin of carotenemia? Anybody? Who is the cousin of carotenemia? This is another disease which is very similar to carotenemia. What is the antioxidant present in tomatoes? That's another clue. The antioxidant present in lycopene. So this condition is called lycopenia because she is a tomato faddist. She takes a lot of tomato, tomato. So lycopenia, which is very similar to carotenemia, which again may be mistaken for jaundice. Now, there's a big question. Which is correct? Is it scleral icterus or conjunctival icterus? Traditionally, we have been taught by all our teachers or most of our teachers that scleral icterus. In Nelson, it is written as scleral icterus. In Harrison, it is written as scleral icterus. And in even Hutchison and Hunter, it is written as scleral icterus. So, which is actually correct? And who is this? This is none other than, again, I'm very happy to quote him 1 second. This is Sir William Auster, the father of medicine. You know how William Auster defined jaundice? Sir William Auster defined jaundice as yellow tinting of skin and conjunctiva. Yellow tinting of the skin and conjunctiva, not sclera. And if you search literature, you can see a lot of articles in reputed journals like Annals of Internal Medicine. According to Cooper, it is conjunctival icterus. See, an article in JAMA, conjunctival icterus and not scleral icterus. Another article on the American Family Physician in 2005. Bissell used the term conjunctival icterus instead of scleral icterus. So, which do you think is correct, scleral icterus or conjunctival icterus? Scleral icterus or conjunctival icterus? Now, we have been traditionally taught that it is the sclerae which are stained. Now, what is the blood supply sclera? What is the anybody? What's the blood supply sclera? You know that the sclerae are completely avascular. Okay, so bilirubin cannot be deposited in the sclerae. This is actually the bulbar conjunctiva surrounding the sclerae that the bile pigment is deposited. That's the reason why it should be actually called a conjunctival icterus and not scleral icterus. Okay. Of course, practically it doesn't make any difference. It is whether it is scleral icterus or conjunctival icterus, but ideally it should be called conjunctival icterus. Now, the problem was that the German anatomists in the early 1930s and 1940s, they said that the sclera is very rich in elastic fibers. Now we know that sclera are actually very poor in elastic fibers also. So actually the term conjunctival icterus is correct and not scleral icterus. Suppose I mention it in the examination and the examiner does not like conjunctival icterus. What will you do? In a postgraduate year, suppose that the examiner is very angry that you are saying conjunctival icterus. You should never argue with your examiner, especially during examination. Never argue with your examiner, even if you're 100% sure that you are right. You can argue with the examiner or can just politely discuss with the examiner, if it's your teacher, that is, it's conjunctival icterus which is correct and not scleral icterus. Okay. In many articles, we find the word transaminitis. Whenever the serum bilirubin is elevated, they write, this patient has got transaminitis. Do you really think this term transaminitis is correct or not? Do you think it is correct? Geeta, who is very fond of spellings, grammar, she always speaks Victorian English. Geeta, do you think transaminitis is correct? Well, I don't think. I think it is absurd. It is as absurd as what Trump has been mentioning, talking nowadays. It's completely absurd. Why is it so? What does transaminitis mean? The term transaminitis means there is inflammation of the transaminases. Do you think the transaminase is inflamed? No. It's actually the hepatocytes which are inflamed. And laboratory test cannot be inflamed. Suppose a patient has got acute renal failure and his creatinine is very high. Do you say he's got creatinitis? No, definitely no. Suppose a patient has got myocardial infarction and his trop is high. Do you say he's got troponitis? No. Similarly, it is as absurd as saying something like this. Suppose I am typing for a very long time and I am saying, sorry, I have got to stop typing because this keyboard is giving me laptopitis. Okay, so don't use the word transaminitis. This is actually not correct. Another case, we had a 14-year-old boy admitted with a high fever, chills, rigor, and jaundice of 5 days duration. He had mild hepatomegaly. What the finding in the eyes? What the finding? The obvious, it is subconjunctival hemorrhage. Look at the bloods. He's got a leukocytosis with striking neutrophilia. His ESR is 110, very high ESR. Bilirubin is only mildly elevated. Transaminase is only in the 80s. Prothrombin time is normal, but the RFT is deranged. His HPSAG is positive. His IgM anticoron antibody is negative, and his IgM anti-HIV is negative. So what the diagnosis? His HPSAG is positive. Do you really think he's got acute virus B hepatitis? No, because his IgM anticoron antibody is negative. In a virus acute hepatitis, IgM anticoron antibody should be positive. So this is not, as the Ashraf has rightly said, that this is the clue for that. What is this? Urine dark-down microscopy. The diagnosis is leptospirosis, rightly pointed out. The next investigation would be a CPK. CPK was 1050. Diagnosis Wheals disease. What about HPSAG? Wheals disease in an HPSAG carrier. He was just a carrier of HPSAG. Okay. Now, it's very important for you to differentiate Wheals disease from viral hepatitis. Many pediatricians bitterly complain that it's very difficult to differentiate these two conditions clinically. Just look at this slide. See, a very abrupt onset in Wheals disease, severe myalgia, constant severe headache, congenital congestion, severe prostration, myocarditis, bleeding manifestation. These are not seen in viral hepatitis. Similarly, what about a simple blood test? You don't have to wait for the serology, which becomes positive only after 1 week. Look at the serology, striking leukocytosis, neutrophilia, very high ESR, thrombocytopenia, hematuria, albuminuria, and the RFT is deranged, CPK is high. It's a very easy to differentiate viral hepatitis from Wheals disease. It should not depend upon serology. Another case, this case also I saw very recently, a 3-month-old, very sick-looking baby with a congenital cyanotic heart disease with congestive cardiac failure. Okay, complicated congenital cyanotic, complex congenital cyanotic heart disease. She had a tender hepatomegaly. Look at the transaminases, very high, more than 3000. The bilirubin is only 2.5 milligram per cent, alkaline phosphate is normal, septic workup normal, viral markers were negative. What is the cause of this? What is this child suffering from? Is the close-up here the same patient? What could be the diagnosis? A child with congenital cyanotic heart disease with acute congestive cardiac failure. So this condition is called shock liver or ischemic hepatitis. Okay, in ischemic hepatitis or shock liver, because of the ischemia to the liver, because of congestive cardiac failure, the transaminases will be very high, more than 3000. But you know that 3000 transaminases may be seen in viral hepatitis or virus B hepatitis, that the transaminase may be 3000. So what is the next test to be done to differentiate these two conditions? That a very simple test, LDH. LDH will be very high in toxic or shock liver or toxic hepatitis, whereas LDH will be relative normal in viral hepatitis. So it's actually very easy to diagnose this condition. So this is a picture depiction of this relatively rare condition, shock liver or ischemic hepatitis. Extremely high values of transaminases and LDH. But all these will subside very rapidly once the congestive cardiac failure or if there is sepsis, these are corrected. Another case, we had a 10-year-old tribal girl with a recurrent abdominal pain, fever with rigor, hepatomegaly, firm hepatomegaly, no splenomegaly. Her hemoglobin is 7 grams per cent, serum bilirubin is 4 milligrams per cent, ALT is only minimally elevated, prothrombin time is normal, and ESR is 90. Ashraf, can you hear me? I don't know.
We can hear you, sir.
Okay, so this is the USC finding. Okay, what is the full diagnosis in this child? What is the full diagnosis? I want the full diagnosis. Let's just look at the face of the child, ultrasound scan. You can see that the gallbladder is inflamed. The full diagnosis. You want a clue? You want a clue? This is the clue. This is the clue. Look at her bunion. Pinarayi Vijayan. Where a clue?
Nabil already answered. Sickle cell disease.
Nabil, okay, Nabil. Nabil is one of the wonder boys of Calicut PGs. Okay.
Nandakumar also from Kannur.
Okay, Kannur Nandakumar. Nandakumar, you are here. Thank you, Nandakumar. So this is indeed, this is the peripheral showing sickle cells. But what is the full diagnosis? My question, what is the full diagnosis? Sickle cell anemia is not the full diagnosis. Look at the ultrasound. can see that the gallbladder bed is inflamed. You can see acoustic shadows. Gita P, radiology, that is gallstones. So the full diagnosis is sickle cell anemia with calculus cholecystitis. That's the reason why the ESR is very high. This patient does not have a splenomegaly. Okay. What is the synonym of sickle cells? Sickle cells are also known as drepanocytes. Now, what's the most commonly done surgery in sickle cell anemia? I have very frequently asked this question to postgraduates. What's the most commonly done? Any postgraduates? The most commonly done surgery in sickle cell anemia? Quick. Most commonly done surgery in sickle cell anemia. Many postgraduates say.
From Nabil, cholecystectomy, Nabil.
That's again Nabil. It's not, yeah, absolutely right. It's not splenectomy. Who does splenectomy in sickle cell anemia? It is Uparwala, GOD. Okay, it is a medical splenectomy. Why cholecystectomy? Because they tend to develop gallstones or calculus cholecystitis. What type of gallstones do they develop? Another question. They tend to develop in hemolytic anemia. They usually tend to develop black pigment gallstones. The black pigment gallstones. This is the lemon color of conjunctiva in hemolytic jaundice. This is the comparison. Now, who described thalassemia first? Who's the first person to describe thalassemia? What's the other name of thalassemia? Thalassemia is also known as Cooley's anemia by Thomas Cooley. Ashraf, along with Thomas Cooley, there's one more person. You want a clue for that? Clue? Yes or no?
Yes, definitely.
Yeah, this is the clue.
Bruce Lee Allah.
Bruce Lee Allah, it was Dr. Lee in 1925. Okay, not Bruce Lee, but Dr. Lee in 1925. Now I'm going to show a clue which Geeta MG will not like. For the first Indian to describe thalassemia. I'm really frightened when Geeta is in the audience because she.
Why should you be, sir? Absolutely.
This is the reason. This is the reason. Her cousin is the first Indian.
Mukherjee.
And who is
it's not Geeta Ji, but Mukherjee.
It is not Geeta Ji. And the cousin of this lady is Rani Mukherjee, but she didn't describe it. It was Dr. Mukherjee. Geeta Ji Madhuri, Dr. Mukherjee. And you talk like the Geeta Ji alla Mukherjee.
Nice slide. Very nice slide, sir.
Thank you so much. Okay. Okay, right. Anyhow, that was described by Dr. Mukherjee from Bengal in 1935. So it's very easy to distinguish the various types of jaundice just based on a urine examination. Look at hemolytic anemia. What's the other name of hemolytic anemia? It's also known as echoloric jaundice. Chol means bile. Echol means no bile in the urine. So in echoloric jaundice or hemolytic jaundice, there's no bile pigment in the urine, but urobilin generally present. The hepatocellular jaundice, what happened? Both will be present. In cholestatic jaundice, urobilin generally absent. So just by a simple examination of the urine, it's possible. Krishnamara Kanandandella, good. It's quite possible to differentiate the various types of hepatitis. Look at the LFT in the various types of jaundice. Hemolytic jaundice, the LFT will be essentially normal, apart from the mild elevation of unconjugated bilirubin. In hepatitis, what happens? The transaminases will be very high, but in cholestasis, the alkaline phosphatase will be very, very high. So that's how we differentiate various types of jaundice by LFT. Now, what is high-slow? What is high-slow? Hyman Zimmerman, which is a very famous clinical hepatologist, had once remarked that if the SCPT is 3 times above the upper limit of normal with jaundice due to drug toxicity, then the chance of mortality is almost 10 to 50%. Very high mortality of 10 to 50%. So if you start ATT on a child, and the SCPT is becoming very high, and the child is becoming clinically icterus, then this baby is developing fulminant hepatitis. It's very important to monitor all children on such drugs. Okay. So to the take-home messages, the most important test in hepatitis is actually prothrombin time. You should always monitor ALT in children on anti-tuberculous treatment. Why I say is that we had a lot of children with ATT-induced fulminant hepatitis failure. I still remember one of my PGs, one of the best PGs. You should always do an SCPT before starting ATT. And this particular PG had done is the SCPT before starting ATT. And after 1 month, after 2 weeks, this child developed hepatitis, fulminant hepatitis. Okay, so I always do SCPT. I repeat SCPT nowadays after 2 weeks also, because this child developed fulminant hepatitis, was very sick, and he had to be rushed to Amrita for a liver transplantation. At that stage, we had the epidemic of H1N1 also. We had sent the blood for H1N1, and the result came as positive. This child was actually posted for liver transplantation. Just in the nick of time, I told Dr. Geeta that H1N1 is positive, but put on oseltamivir and the child recovered. We have seen a lot of children with the fulminant hepatitis due to ATT. So when you start ATT or anti-platelet drugs, we have to tell the parents that if the child develops jaundice, ATT should be immediately stopped, and you monitor the patient very carefully. So stop the drugs immediately. When AST is more than ALT, that the diuretic ratio, think of other conditions like Wilson's disease. Very low alkaline phosphatase, they can think of Wilson's disease. We already discussed the cause for that. Very low albumin, think of chronic liver disease. If the ALT is very high, it may be toxic hepatitis or a shock liver. A dramatic fall of ALT. Suppose the ALT on day 1, day 5 is 3000, and day 7 it becomes suddenly 500. That means a lot of hepatocytes are suddenly destroyed. That, along with the rising bilirubin and prothrombin time, is a very bad prognostic finding. Then you should always remember that all that yellow need not be jaundice. Also think of carotenemia as well as leukopenia. Then you should always believe the mother. She is likely to be correct. Again, I would like to quote one more example. You know that all children are precious. This was the only child after 15 years of marriage. More precious, definitely. So this child had recurrent lower respiratory infection. Okay, because of very frequent lower respiratory infection, this child was put on ATT. After 1 month, the mother took the child to the pediatrician and said, "Doctor, I think her eyes are yellow." Doctor, മോളുടെ കണ്ണിലെ മഞ്ഞ നിറമുള്ളമായിട്ട് തോന്നുന്നു is what it said. The pediatrician became angry. He did not look at the eyes of the child. Instead, he scolded the mother. He told the mother that something is wrong with your eyes. You go to an ophthalmologist and get your eyes tested. The mother became very happy because she thought that the child was having jaundice. But the big doctor is saying that the child does not have jaundice. The mother continued ATT, and after 5 days, the child was admitted in IMCH, and it died before a liver transplantation could be done within 2 days. So we should always believe the mother because she is likely to be correct. Thank you so much for listening to me.
Thank you, sir. Thank you for that excellent talk. And I think the most important take-home message is as far as the children are concerned, the mother is the most concerned person about the children. It is not you, it is not me, it is not the doctor, but it's the mother. We are very sorry, sir. Even though several persons are knocking at the window of Zoom is not permitting enter them because of a restriction of 100. We purchased a paid version today, but it will take 48 hours to get the YouTube streaming. That was the problem to many. Anyhow, we recorded the talk. We will discuss with you about uploading it to YouTube. With your permission only, we will upload after the discussion. Now the topic is open for discussion. If you have any questions, any doubts, you can send a message to chat box. We will unmute you. I invite Dr. Bala, the Dynamic Secretary of Kerala IAP, for comments. Ranjit, please unmute Bala.
Hello, sir. What to say about Riyaz's talk? Very excellent. Yesterday also I heard about Riyaz's talk. Last month also at Shornur I had one talk. So nothing to say about Riyaz, sir. Everybody knows that. And IAP Kozhikode has done a grand beginning to the Rainbow, the webinar series with the Riyaz's talk. Actually, I could get in only at 8:30. I was just 5 minutes late, and I could because of Ranjit only I could get in at 8:30. So I congratulate IAP Kozhikode for the excellent planning. I hope this program will go on well. With hopefully by day after tomorrow we will be able to upload in the YouTube. And thanks once again to Riyaz sir for the excellent talk. Thank you.
Thank you very much, Anand.
Anybody? Shaji sir? Ranjit, please unmute Shaji sir.
Riyaz, as usual, you did a wonderful job. It was really nice listening to you, listening to my classmate. All I
Thank you,
sir. Thank you. Chat box. I will check the chat box.
Lulu madam is there, sir.
Lulu madam is there. Madam, please unmute madam. Madam is tomorrow's speaker.
Hello.
Yeah.
Kekamo.
Yes, madam. Kekam, madam.
Kekam. Okay. Hearing Riyaz after a long time. So many years, and enjoying every minute. So nice, Riyaz. So nice.
Thank you so much, Lulu. Thank you so much. It's really an appreciation.
Just,
really nice
I want to take it
to be appreciated by a person of the caliber of Lulu.
Riyaz, just an anticipatory bail. You have started it off well. The others should not think that all of us will follow your path.
It's very difficult to speak after Lulu Mathis, and we all know that. Very difficult.
ഏതായാലും ആ ആർഗ്യുമെന്റ് അങ്ങനെ തന്നെ തുടരാം നമുക്ക്. നാരായണ സാർ പോയോ? സ്റ്റേറ്റ് പ്രസിഡന്റ് ഉണ്ടോ? നാരായൺജി.
Because we have been hearing Riyaz for so many years, and every time he is bringing newer points and making the talk enjoyable. It's just a real experience for all of us. Wishing to hear sir in future too frequently. And of course, congratulations delegate team for the fantastic show you have put up.
Dr. Narayanan was one of my best students, belonged to the 25th batch of Calicut Medical College. And I still remember Narayanan and Jayakishnan when I went to ICH. In fact, I had stayed in his room when I went for DM training in ICH way back in 1993. I had gone for a 1-month training in the Pediatric Gastroenterology Clinic of ICH. Jayakishnan, Jayaram, Narayanan,
Jayaram Shankar.
Whether the Jayaram from Palakkad is there?
TPJ, I used to call him. There are actually 2 TPJs. One is the big TPJs, and Matthias Namada TPJ from Palakkad.
Vijay Kumar, Ranjit, please unmute Vijay Kumar. If any past presidents are there, please unmute.
Purushottam sir is there.
Purushottam sir. Welcome Purushottam sir. Please unmute. Nandakumar is there from Kannur.
Purushottam sir is.
ഒന്നുമല്ല, എനിക്ക് രഞ്ജിത്തിന്റെ അടുത്ത് പറയുന്നത് യൂട്യൂബിൽ അപ്ലോഡ് ചെയ്യുമ്പോൾ ലോട്ട് ഓഫ് ഫോട്ടോസ് അതർ. അപ്പം റിയാസ് സാറിനോട് ചോദിക്കണം അവരുടെ ആ ഒരു ഫോട്ടോസ് അപ്ലോഡ് ചെയ്യുന്നതിന്റെ.
അതുകൊണ്ടാണ് ഞാനത് പറഞ്ഞത് സാർ. അതായത് we will discuss with Riyaz sir. Only after that we will upload.
Okay.
Because photos are there.
Ashraf എന്താന്ന് വെച്ച് കഴിഞ്ഞാൽ it's very unfortunate. ഒരുപാട് ആൾക്കാരെ വിളിക്കുന്നുണ്ട്. More than 200 ആൾക്കാരുണ്ടായിരുന്നു. And I was really shocked, literally shocked. കാരണം ഇന്നലെ 230 ആൾക്കാർ വന്നായിരുന്നു.
അത് മോസ്റ്റ് ഓഫ് ദം യൂട്യൂബ് സ്ട്രീമിംഗ് ആണ് സാർ. അപ്പൊ നമ്മൾ എടുത്തു കഴിഞ്ഞാൽ 48 hours എടുക്കുമെന്ന് നമുക്കും അറിയില്ലായിരുന്നു. നമ്മൾ ഇന്നലെയാണ് പർച്ചേസ് ചെയ്തത്. ഇതുവരെ നമ്മൾ IAP സ്റ്റേറ്റിന്റെ ഉപയോഗിക്കുകയായിരുന്നു.
അപ്പൊ as Pirish is rightly pointed out, ഇത് യൂട്യൂബിൽ ഇട്ട് കഴിഞ്ഞാൽ ഒരുപാട് പേഷ്യൻസ് ഫോട്ടോസ് ആണല്ലോ.
പിന്നെ അത് മാസ്ക് ചെയ്യണം സാർ. നമ്മള് സ്ലൈഡില് ഓഡിയോ വെച്ചിട്ട് എഡിറ്റ് ചെയ്ത് ചെയ്യാൻ പറ്റുമെന്ന് നമുക്ക് ഡിസ്കസ് ചെയ്ത് തീരുമാനിക്കാം സാർ.
പേരുകൾ മാറ്റുക. യു ക്യാൻ ചേഞ്ച് ദ നെയിം ടു ദ പ്ലേസ്. അത് അവോയ്ഡ് ചെയ്യുക. മറ്റേ ഫോട്ടോസിനുള്ള ഐ കവർ ചെയ്താൽ മതി.
Sir, really wonderful talk, sir. Really very informative. We are missing you in Kannur, actually. So that's the only thing. Sir. We are really missing you in Kannur.
Thank you, Nandan.
Okay, sir.
Thank you so much, Nandamar. Thank you so much.
Okay.
Nandamar belongs to the 29th batch,
my classmate.
Sir, 29th batch.
29th batch. Bangar Shalbert, Arshab, Nandamar,
Mohandas.
Ajit Kumar,
Mohandas, Ajit Mohandas.
and so many people. Great batch. Unfortunately, I have not participated.
Sir, undergraduates ഞങ്ങൾക്ക് ഉണ്ടായിരുന്നില്ല. സാർ അന്ന് ആയിരുന്നു.
അതെ.
ബാത്റൂമിലെ വായിലോർത്തോ?
അപ്പോൾ വേറെ ആരെങ്കിലും ഉണ്ടോ?
നല്ല തുറന്നിട്ടുള്ള.
Anybody else? Then over to Nihas for vote of thanks.
I take this opportunity to thank Riyaz sir. A point of apology also, sir. We never expected that YouTube thing won't work today. That was the latest thing which we came to know last minute. Anyway, after discussing the plan of uploading the video, and I thank you for this nice talk once again. We've been hearing you for many times. How many times we hear also, like, it will be like so new and so interesting and so informative. The talk always. I also take this opportunity to thank Dr. Basavaraj, who came and inaugurated this Rainbow series, which is planned over next 7 weeks. And though we called him the last minute today morning, he accepted our invite and came over and came online and inaugurated something. Again, thanks to Unexplained sir for coming. And also I thank our state officers, Aran sir and Bala sir, for all the support and help to IAP Kozhikode. And also want to thank Dr. Ranjit, who is being behind the scene, doing all the work, making the Zoom ID and coordinating it together. Thank you, Ranjit. And all other seniors, teachers, and Salvos and IAP who came over for this meeting. And we expect your coordination for the next talks also. We are having the next talk tomorrow, and we are having 3 talks every week for next 7 weeks. That is the rainbow system. Actually, in the start, Yasser was telling we planned for 5 talks. May was made as 7. Then slowly it went over to 7 weeks. So the name rainbow was made as 7 weeks, and each week is given a color according to the week year. So this week is a violet color, and Yasser started the talk session. Thank you, sir, again, and thank you all who came over.
As far as the COVID is concerned, red zone is alarming. But with your NCT red zone, by 7th week, നമുക്ക് പ്രതീക്ഷിക്കാം നമ്മൾ റെഡ് സോണിൽ നിന്നൊക്കെ മാറി നമ്മൾ സൂം മീറ്റിംഗിൽ നിന്നും ഔട്ടായി പഴയ പോലെ എത്തുമെന്ന് ബൈ 7 weeks. Hopefully. Okay. ബാസ്വരാജ് സാർ പോയോ? നിഹാസ് ഉണ്ടോ? പോയി. Okay. Anyhow, happy birthday to him. Thank you all. Thank you, Dr. Narayanan, Dr. Anandakeshavan, Baswaraj, Riyaz sir.
Anandakeshavan സംസാരിക്കാൻ മറന്നു കേട്ടോ.
Anandakeshavan ഉണ്ടോ? രഞ്ജിത്തെ കഴിഞ്ഞോ? പോയിട്ടുണ്ട്. It is almost 9:35 sir now.
നാളത്തെ ടോക്കിനെ പറ്റി സാർ ഒന്ന്
നാളെ tomorrow pain management by Lulu madam. Tomorrow. Pediatric pain management by Lulu madam. ഞാൻ ചാറ്റ് ബോക്സിൽ ഇട്ടിട്ടുണ്ട്. അപ്പൊ പിരിയല്ലേ? ഭക്ഷണം ഇല്ലല്ലോ നിഹാസ്? ഓക്കെ. ഇന്ന് നിഹാസ് ഓർക്കാൻ മറന്നു. പറഞ്ഞ രഞ്ജിത്ത്.
ദാമോദരൻ സാർ ആരോ സംസാരിക്കും.
ദാമോദരൻ. Welcome, Damodaran. Welcome, Dr. Damu.
Damu, no?
Yeah.
Damu.
ആരോ പറയാൻ വന്നു. ഓക്കെ.
കട്ടായി അല്ലേ? പിരിയല്ലേ?
Okay.
Let us disperse. Good night.
Good night.